Okay, well, thank you everybody for logging on today. We're getting our second season of our advanced heart failure conferences going. And today we have a great topic to kick off the discussion. I think something that we probably in our clinical practice, would have questions about what would be the best thing to do in the situations that our speaker is going to be talking about, and see if she might provide us with any additional information about how we can then best treat these patients. So today we're very happy to welcome Rachel Eaton. Rachel is a graduate of Clarkson University and the Albany College of Pharmacy in upstate New York. She completed her PGY-1 residency at Nebraska Medicine, followed by a cardiovascular specialty residency at The Ohio State University. After spending time as a cardiology pharmacist at Brigham and Women's, she has returned to The Ohio State University as the vascular surgery specialty practice pharmacist. Her clinical practice interests include peripheral arterial and aortic disease, anticoagulation, pulmonary arterial hypertension, and heart failure. So on behalf of her research team, Rachel is here today to talk to us about the results and clinical implications of her prior residency research project, which was entitled Rehospitalization of Patients with Advanced Heart Failure Receiving Continuous Palliative Dobutamine or Milrinone. So thank you so much, Rachel, and please go ahead and take it away.
Absolutely. Thank you so much for the introduction, Dr. Beasley. And thank you so much for having me here today. I'm very excited to talk about this topic. To kick things off, I would love to introduce my study team. I worked with Drs. Pickworth, Kissling, and Dr. Haas, as well as our statistician, Eric McLaughlin. This project would not have, wouldn't be what it is without them. So I'm very fortunate to have worked with them. And overall, besides what's listed on the screen, we don't have any kind of disclosures with this topic. As I'm sure that many of you are very, very aware, we take care of patients that have advanced stage D heart failure. And ultimately, as we are helping them, work up, helping them support these later stage of disease, ultimately our first options are optimizing GDMT as well as device therapy. But as we know all too well, and unfortunately, a lot of the times these patients have to go down the road where they're either candidates for cardiac transplantation or mechanical circulatory support. And then unfortunately, if they're not candidates for either of the aforementioned, we turn to palliative care and these different types of ways to support patients in the later stages of disease. The study question that I'm presenting here today, there are definitely some limitations as far as the previous trials go that helped us lead to this question. So we knew that there were gaps in the literature about palliative inotropes. These studies were really riddled with small sample sizes. They used very much higher inotrope doses than we use in clinical practice. And the data based on selection, there wasn't all that much data about which agent to use. These trials also preceded our most current contemporary standards, so guideline-directed medical therapy and device technology, and ultimately didn't really lead to very clear conclusions on how they impacted patient outcomes in this advanced stage of disease. Ultimately, a lot of these trials also excluded patients that had a palliative indication for therapy. And so we were able to formulate this research question for our patients that have end-stage heart failure. Does the utilization of continuous intravenous dobutamine versus Milrinone impact the incidence of all-cause hospitalization? And a little bit later on, I'll dive into why we picked incidence of all-cause hospitalization, but I'll give you a little bit more on the methodology here. It was a single-center retrospective cohort study. Ohio State is a tertiary care academic medical center. We have a comprehensive cardiovascular center. We do offer both heart transplant and ventricular circulatory support for qualified patients. We are a 172-bed heart center here. And we were able to look at patients with stage D NYHA functional class 4 heart failure. And we looked at all the patients that were discharged on either dobutamine or Milrinone for palliative intent from our center. And we looked at data for a little less than 5 years. And ultimately, we are trying to figure out what the incidence was of all-cause hospitalizations in this patient population between these two agents, specifically for palliation. We have our inclusion criteria here, and overall we looked at 6 months of therapy. Our dobutamine group ended up including 135 patients, with Milrinone having 87. And just kind of a note on this moving forward, we included 6 months for the primary outcome, but then as you'll see in some of our other outcomes, we did look further. We looked until the last point of patient contact. As far as exclusion criteria goes, I have it listed here for you. Some of note, we didn't exclude anyone who was receiving inotrope therapy for another indication, anyone who was deemed to be a candidate for advanced therapy, or those patients that had isolated right heart failure or were discharged on multiple inotropes during the study period. As I stated, our primary outcome was the incidence of all-cause hospitalization within 180 days of that index discharge event. So the first time they were discharged on either Dobutamine or Milrinone. We looked additionally at some secondary outcomes. We looked at the cause of hospitalization, so whether it was attributed to worsening heart failure, some sort of infection because of the central line that they had to be discharged with, thrombosis related to that line, or the incidence of arrhythmia. We also looked at days alive and out of the hospital, which again, I'll dive into a little bit further on in this presentation. We looked at the hospitalization rates pre and post initiation of inotrope. We looked at time to death as well as hospice status, which turned out to be one of our most interesting findings. This is just a little flow chart. It's included in the paper about how we went through patients. So through that 5-year period, we looked at a little over 400 unique discharges. There were 75 patients that didn't meet inclusion criteria, 126 that were excluded for the various reasons that I have listed there. We ultimately ended up including 222 patients that received either Dobutamine or Milrinone during the study period. As far as our results go, the patient baseline characteristics that we found, our patients were predominantly male. The patients that were in the Milrinone group were a little bit younger, and they also had a lower baseline BNP. The mean ejection fraction was the same for both groups. And like I said, BNP was a little bit lower in the Milrinone group. Average age was 61. The majority of patients had non-ischemic cardiomyopathy, and over 90% of them had concurrent pulmonary hypertension as well. And I have a little bit more of that on this slide here. But overall, even though there was a high incidence of a lot of these comorbidities, there wasn't any statistically significant difference between the two groups at baseline for these particular comorbidities. We also looked at baseline discharge medications to see if patients, discharged on one or the other, were able to continue guideline-directed medical therapy. And we did find that patients in the Milrinone group were more likely to be continued on their beta blocker, as well as their aldosterone antagonist. And then we also looked at location of discharge. We found a pretty vast difference. We found that about 30% of our patients that received Dobutamine went on to either inpatient or outpatient hospice, whereas this number was much lower in the Milrinone group, and it was only about 6% of the overall population. When looking at our outcomes, so our primary outcome again was rehospitalization within 180 days of discharge. We did find that this was actually statistically significantly increased in the Milrinone group as opposed to the Dobutamine group. However, when we looked at the time to first rehospitalization compared by group, there was no difference in the time. And through this primary endpoint, we looked at death as a censored event. And I think that one of the most interesting things that we did during our trial was that we actually ran a multivariable analysis to look at the patients that were so looking at the overall population with those patients that went to hospice excluded, because the numbers were so different in our Dobutamine population. And we actually found that when we looked at the primary outcome in patients, in just our patients that did not go to hospice, that difference that we saw in rehospitalization was no longer valid. Which kind of continues to be a theme throughout the rest of our results and our analysis. When we looked at survival in the Milrinone arm, overall mortality was lower and survival was longer. So this was the difference, and I had the numbers listed there for you, but we did see overall survival improved in the Milrinone group versus the Dobutamine group. And we did see over time that there were about 10% of patients that were still alive at 1 year, which is pretty consistent with what we see in the existing literature as well. Again, when looking at patients that were excluded, looking at our overall population with hospice excluded, we did see that mortality remains significantly lower in the Milrinone group, and the median overall survival continued to be longer in the Milrinone group. So when we excluded hospice, those differences those positive differences that we saw for Milrinone stayed significant. I have those numbers listed here for you. As far as rehospitalization or death, also known as days alive and out of the hospital, we did see that patients that were, there was a longer time that patients spent out alive and out of the hospital in the Milrinone group. And the time to first rehospitalization or death compared to inotrope type, again, was significantly longer in the Milrinone group as well. And I think that difference, when we put it into chart form, it looks a little bit more clear as well. So in regards to days alive and out of the hospital, we looked at, day 0, and then we looked at day 30 and day 90. And we took the overall proportion of patients that were, again, alive and not hospitalized. We took the overall proportion of those numbers and we compared them to see, are these patients able to remain out of the hospital, hopefully asymptomatic, at home with their loved ones. And we were able to see statistically significant differences at both 30 days and at 90 days. And I think the difference at 90 days is really astounding there, that, 70 days versus 37 days. When we excluded patients that were discharged to hospice, this difference that we saw, particularly at 90 days, remained statistically significant. Again, when we excluded the patients discharged to hospice. To try to account, so I said this was a retrospective study. This was a study, that we did over the year that I was a PGY2 resident, 1-year analysis. So we had to formulate it. It had to be a retrospective cohort study. So we tried to do some multivariable confounders, and we looked at pulmonary hypertension, ventricular arrhythmias, beta blocker utilization, blood pressure, and creatinine to try to see if any of these baseline differences could potentially have impacted what we saw in our final results. And what we found, just in a broad sense, and I'll dive into this on the next couple of slides, is that there was a time variable effect of the treatment type. So later on in the hospitalization, Milrinone did display a higher hazard of hospitalization, whereas there was decreased mortality earlier in the study period. We saw broadly that beta blocker utilization was independently associated with a decreased risk of rehospitalization. And we also saw that the presence of pulmonary hypertension and worsened serum creatinine from baseline was associated with poorer survival outcomes, and that was independent of the inotrope that was selected. Took some screenshots of the paper itself. And I think the one part that I'll dive into here, I won't go into all the numbers. I know it's a lot of data on the screen. But I think the one point we wanted to make was when we took death and we made it a competing event, we looked at the multivariable analysis for rehospitalization. And again, we found that it varied with time. So there was increased hazard of Milrinone over time. Patients on beta blockers had a longer time to rehospitalization. And we are able to see some of the other differences here, again, when we treated death as a competing event. And this was particularly, again, for rehospitalization. We also looked at this for survival. And again, it was varied over time. In times closer to the initial discharge, the hazard of death was significantly lower in patients that were receiving Milrinone. And then over time, that became insignificant. So again, attributing to the fact that Milrinone probably had a lower hazard of death earlier on in the study period. And then we also saw here that this is where we saw the baseline serum creatinine levels when they were elevated, and baseline pulmonary hypertension also correlated with a higher risk of mortality. So I have some of these highlighted here for you. With this being a retrospective single center cohort study, there definitely were some limitations to our study. We were only able to look at a pretty limited patient population because we were only able to kind of pull the data that we could see in EPIC. We only were able to look at patients for 5 years to try to achieve the number that we needed for power. And with that, we were only able to collect data that was made available to us. I think one of the other interesting things that we did, which could be a limitation or could have given us some different insight, we did look at different lengths of therapy. So with collecting data over 5 years. For some patients, we had, a year's worth of data. For other patients, we were only able to capture those first 6 months after discharge. So again, different lengths of therapy could have impacted what we saw. And then over time, I think, some of my colleagues can probably speak to this that have been doing this longer than I have, but there's definitely non-clinical factors that have changed over time as well. So whether that's insurance coverage, whether that's patients being discharged to skilled nursing and them having an inotrope preference, shortages like we've seen very recently. So there's definitely some non-clinical factors that can play into agent selection as well. I'm very much looking forward to seeing other points that people have for discussion, but in some very broad terms, the biggest thing we wanted to pull from our study was that in this patient population, so advanced heart failure, not a candidate for advanced therapies, we saw no difference in hospitalization between Dobutamine and Milrinone when patients that were discharged to hospice were excluded. I think that finding, that difference that we saw, the 31% versus 6% between the groups that were discharged, really kind of changed how we looked at this entire analysis. And we thought that was really the biggest take home point for this study and one of our biggest discussion points. We also saw that among all patients that were rehospitalized, those receiving Dobutamine were hospitalized sooner, whereas those receiving Milrinone they also had a higher incidence of death and lower overall survival. So our patients that were receiving Milrinone were more likely to spend days alive and out of the hospital, and they were more likely to continue on guideline-directed medical therapy. And I think that last bullet brings up a couple of important points too, right? So with the fact that the effect of inotrope selection being variable over time, we saw that later in the study period, there was potentially more hospitalization, but earlier in the study period, we did see that decrease in mortality. And I think that the way that we interpreted that is that we really need to be looking at patients' goals of care, and we need to be picking agents that are going to align with the trajectory of their personalized disease state and the trajectory of disease. For example, selection of Milrinone might be more appropriate for those who don't qualify for advanced therapies, but they could potentially have a longer anticipated trajectory of survival. And I think the days alive and out of the hospital was something that we found when we were trying to figure out how to build this study. And it's an interesting outcome because it's able to account for multiple events and event severity, but it does so in a patient-centric approach. And we thought we actually went back and forth whether to make that the primary outcome, but we ended up making it a secondary one. And for us, that was one of the biggest take homes. That's precious time for our patients to spend, whether it's, we looked at it on the scale of days, but in our Milrinone group, we saw, a month where patients could be at home spending that time with their loved ones. And while our trial does have some limitations, we think that was really one of the biggest take home points from what we found in our analysis. So we do think that moving forward, there's some data out there about, quality of life. We know that patients prefer to pass when they're at home. We know that over 75% of heart failure related hospitalizations occur in the hospital, despite the fact that people want to be at home. So we thought that, when we excluded our hospice patient population, as well as looking at our days alive and out of the hospital, we definitely found some important things that will likely change how we treat our patients here. So in conclusion, we know that there's limited data related to the study question. I've definitely seen some more trials even since we've published this that have come out that continue to debate this question. We found that there was no difference in rehospitalization when patients discharged to hospice were excluded. As the primary endpoint in the overall population, we saw that Dobutamine potentially had some favorable decreases in rehospitalization, but again, some of our other findings, our patient population nullified that finding. And then we found that Milrinone was associated with decreased mortality and longer survival. Really, like I said, biggest take home point is that agent selection has to align with the patient's trajectory of disease, and that depending on what we think is going to happen, how we anticipate their trajectory going, agent selection can mean that they could potentially be spending more precious time at home with their loved ones. We definitely need more trial data, though, to validate mortality and quality of life outcomes in this patient population. thank you so much for listening to the little spiel on our project. And I would love to take any questions or discussion points that we have.
Yeah, well, thank you so much, Rachel, for sharing your work. I would like to open it up to the group. If anybody has a question for Rachel, please feel free to unmute yourself and you may ask, or if you want to drop it in the chat and then I can ask it for you, that'd be fine. So I guess while we're waiting for any questions to come out, Rachel, I guess how would this, if you had a clinician approach you as a kind of as a curbside consult and say, I have this patient with advanced heart failure, and they're not going to be a candidate for heart transplant or LVAD. Which of these two inotropes would you recommend I use? I guess what factors are you going to look at to kind of push yourself to recommend one or the other, or would you always probably gravitate to your more preferred inotrope?
No, and I think that's a great question, right? Because that's ultimately what it comes down to. I think that really the comment about agent selection having to match what the patients, one, are looking for, and two, their own specific factors. So I think that we obviously have to look at, hemodynamics, make sure that the patients are ready and willing to either get Dobutamine or Milrinone if they're able to support either or from a blood pressure perspective, from a additional agents perspective. But I think that if all hemodynamics are made equal and we are choosing, in a perfect world where insurance covers both, there's no shortage. I do think that Milrinone is potentially, based on our data here, I do think that I think about it a little differently now. When I first started, in cardiology as a resident, I think that, and this potentially could just be a center's difference, but I feel like we gravitate to Dobutamine as our first inotrope agent. And then Milrinone kind of being a secondary one. And that changed a little bit with the shortage. But I do think that based on these findings, I would preferentially have Milrinone in my head for, again, what we're treating our palliative patients. So I think that in a world where everything is equal for our patients, that's the first agent that comes to mind.
That's really interesting how you bring up the point of there being differences in practice across centers, because in my experience here at Yale, we're much more likely to, or prior to the shortage at least as well, much more likely to have discharged somebody on Milrinone versus Dobutamine. And without any good data to support it, it was just kind of, that was the clinical practice and kind of in what we were doing more comfortably. In the absence of maybe some, advanced renal disease, and those were the patients that we had pushed towards Dobutamine. And that was the one thing when I was looking at your data, I was trying to figure out, why would you have that group that was on Dobutamine possibly having that higher mortality signal? Initially, I was wondering if it was tied to their renal function, but then I saw in your table that there really wasn't much of a difference between baseline renal function between your two groups. So that was very interesting.
And we wonder too, kind of going through the patients, we felt, I feel like looking at the raw numbers, the Dobutamine group was kind of objectively sicker. If you just look at some, they were a little bit older, they had higher BNPs, depending, I obviously didn't take care of all of these patients, but I think we have some data points that would suggest that maybe they were worse off at baseline. But it is an interesting point that you bring up too, just about our raw numbers. We had way more people just at baseline when I first pulled the patients that were discharged on Dobutamine. And again, going back to some of our limitations, I don't know exactly what was preferred back then, whether it was an insurance issue, things like that. But there's definitely some just benefits, logistical benefits to Milrinone as well. Not talking so much about our patients with advanced renal disease, but it is a longer half-life. So if there is an issue with, getting bags, or if therapy runs out, if the IV becomes dislodged, there's potentially benefit to having the inotrope on longer. I guess you could say the opposite in some effect as well. But that is you bring up some excellent points as well.
Yeah, and then and the other thing I found was interesting was again, kind of more about practice habits, or maybe what community you're working within. But for us, for example, I mean, it's basically impossible to discharge somebody to hospice with an inotrope. You know, and I don't know if the way I interpreted your paper is that they were going to hospice and continuing their inotrope in hospice. And that's not something that we've seen here, except for if we're discharging them to one of our local hospice houses. But even if they go there, there needs to be an agreement for them to discontinue the infusion after a certain period of time. So it's not an indefinite thing. And then going to short-term rehab centers, it's definitely impossible. Like nobody wants to take a patient on inotropes at like a sniff or something like that. So is that different than in Ohio, where you have that option to discharge to those settings without any trouble?
Yeah, I mean, now I'm thinking back about all the patients that I collected on. We only included them if they were able, you know, if they went out with a discharge prescription for the inotrope agent. So I guess for those, you know, 30 and 6 patients, we didn't have an issue with it. And I don't know if that goes back to, that's interesting. Yeah, I hadn't heard that before, but I don't know if it goes back to us, you know, explicitly saying that it's for palliation and trying to make that argument. But now I'll have to check and I'll have to see. Like I said, I know what we saw in the trial data, but I'm interested to see if we ever do run into it as an issue. And I just maybe miss those patients because they weren't actually discharged on it.
Yeah,
that's an interesting practice difference.
Anybody out there have any questions for Rachel? I know we have a number of people visiting us today from our cardiovascular pharmacy team and also from our palliative care team. So any questions from you guys? I see Corey has unmuted himself, so I don't know.
Yeah.
Corey,
so hey, Dr. Beasley, it's Lionel. Corey's here with me, and we got a couple of other members of the pharmacy team. Thank you so much, Rachel, for your presentation. We joined a little bit late. We had a RAC meeting that kind of was a little bit before this meeting, but I guess my question is, and I apologize if you mentioned this already, but how did you guys capture your like mortality data? Like, I don't know if you guys have a registry maybe that you utilize. And then the second question is just, you know, when I think about, you know, it's great that we're seeing, you know, these patients live longer, you know, on Milrinone, you know, as your data suggests. But what are your thoughts in terms of like quality of life and how that plays into it? And if that's, you know, something that we should be considering.
Yeah, absolutely. So going back to your first question, and again, this is somewhat of a limitation about our study. So the way that we pulled all of these patients, we pulled them based on discharge prescriptions. So all of the data that was collected, whether it was, so we followed them 6 months post that discharge date. And then we followed them ultimately all the way through the end of the study period if there was data to collect for all of our secondary outcomes, so survival, days alive and out of the hospital. But the mortality data, again, is an interesting question because I went through and I actually manually collected on all of that. So we looked at all of our patients, and there is some missing data for a lot of our patients. We were able to pin down a time when either we called it the last point of contact or we had an established date of death, or some around their date of death. But all of that was manually collected. So again, somewhat limited by the fact that we were only able to collect on the data that we had available to us in IHIS. And with your, remind me again of your second question. I'm sorry, I was on
a. It was just related to kind of like quality of life.
Yes. So as far as, so again, when we were analyzing this, we looked at it and we said, okay, well, you know, Milrinone, we have patients that we looked at this as days alive and out of the hospital. And so we did make some assumptions with that, right? We made some assumptions that if they're not in the hospital and they're still alive, hopefully they're not in the hospital because they're symptomatic and they're able to, you know, stay on their diuretic regimen. They're able to stay hemodynamically stable outpatient. So I think that, is it perfect to say that if they're alive and out of the hospital, that means that their quality of life is good? No. And I think that we need to do there's one or two trials out that try to examine the quality of life in these patients. They're referenced in my paper, in our paper. But I think that overall, we do need to do a better job of looking at like what that days alive and out of the hospital actually means. I think that it will be an important outcome as we continue to look at this patient population, but really, any palliative patient population, to try to describe if there is any correlation between, okay, if they're not here, if they're not inpatient with us, if they're not symptomatic enough to come to the hospital, but they're alive, what does that mean? And the way we spun it was that hopefully that's time at home with their families. But whether or not that's, again, a perfect correlation, I can't really say.
Great. Thank you so much, Rachel. And thanks again for presenting to the group.
Yeah, and congratulations on PGY2 cardiology
Thank
program.
you,
I'm
thank you.
very excited to hear that. It's amazing.
Thank you.
Hi, Nora. I see that you're
Hey.
ready.
Hi, I'm Nora. I work in palliative care. Thanks for this presentation. I had one question and one comment. So my comment is there, I think there is really a lot of regional variability about hospices and whether or not they provide these, but they really should, right? We can see we're getting more and more evidence that they're really helping with quality of life. And, the teaching that I always had was, they help with quality of life, but they don't make you live longer. But I'm sort of questioning that a little bit in your presentation. And that seems like at least Milrinone may have, benefit for longevity too. So I'm wondering, what do you think the mechanism is for the differences that you observed between the Milrinone and the Dobutamine pharmacologically? And then so that's my question. And then my comment is, because I think there is so much variability about whether hospices provide these medications regionally. Like when I was in Chicago, it was common. We would discharge people on drips and it was good. And I'm wondering if there's ways to partner, especially now that the health system has bought, I think it's Home Care Plus. They're going to kind of partner with that hospice. I wonder if there's ways to partner with that particular hospice provider to kind of decrease readmissions and also, provide optimal care for the patients by adding that to the armamentarium of things that they do.
Yeah, I think that's still such an interesting point about the differences because I had never, like I said, I hadn't run into that before, that people didn't have that as an option to them. So I think that sounds amazing, especially if you're able to partner with somebody about potentially decreasing readmissions for this patient population. I think mechanistically, so going back to, why we saw a difference, I think that there's a couple of reasons why we could have seen this difference. Some of them good, and then some of them a little bit more like were they just differences in our study? So we do think that at baseline, our Dobutamine group was a little bit sicker. And we do think that, potentially that could just be, we obviously saw a lot more of them go to hospice. We saw some baseline lab abnormalities that would suggest that they were a little bit sicker at baseline. But I think the other important thing too that we saw was that patients on Milrinone, with the way that it works as a phosphodiesterase inhibitor, as opposed to Dobutamine, which works on our beta receptors, patients can continue on beta blockers, which, as we saw in our study, were independently associated with longer survival, and have been, that's been illustrated in all of this, in all of the previous studies. So whether or not, that was the driving force between why we saw this, it is something that could be beneficial. The mechanism at bay lets us keep them on guideline-directed medical therapy longer. Trying to think if I have any more comments. Yeah, I would say I think those are the primary reasons why we saw what we saw. Does that answer your question?
Yeah, thank you.
Perfect, thank you.
Okay. Any other voices out there in the crowd this afternoon? All right, well, if that's the case, well, Rachel, thank you again so much for taking the time to share your study with us. And, this was very, very interesting. And I think it definitely will help us make these clinical decisions for our patients in a more informed way. And, you know, once we can get through the hurdles of the logistics of having these medications available to us, and that's great with Nora's input about possibly the health system having some type of a relationship with an outside organization where we can start doing this again for our patients, because it's limited our ability to discharge a number of patients, and patients that we could have discharged home on palliative inotropes that instead have they've died in the hospital, unfortunately. So well, thank you again, and everybody, thanks for joining us. Next week we will be talking about the role of macrophages in determining somebody's risk of having transplant rejection. So it should be a very interesting talk in the transplant realm. Thank you all.
Thank you all so much.